first we'll interpret ABG. ABG rule 1 is look at pH and PCO2. If pH or PCO2 is abnormal, it means there is acid-base disturbance. That here pH is 7.09. pH is 7.09 means there is acidosis. Normally 7.35 to 7.45. So acidosis. Then step 2 is where it is respiratory acidosis or metabolic acidosis. For that, look at pH and PCO2. If they move in same direction, it means it is metabolic. They are in opposite direction, that is respiratory. For example, if pH is 7.0 and PCO2 is 60, means CO2 is high, pH is low. They are in opposite direction. So that is respiratory acidosis. Here pH is low and PCO2 is low. Both are in the same direction. Whereas mnemonic is ROME, R-O-M-E. Respiratory opposite, metabolic equal or same direction. Here both are in the same direction. Means it suggests metabolic acidosis. Then we will look at bicarb, HCO3. Here bicarb is around 7. So this is a case of metabolic acidosis. That is step 2. Step 3 is we should look for the compensation. In metabolic acidosis, we expect respiratory alkalosis as a compensation. The formula is Winter's formula. Winter's formula is 1.5 into bicarb plus 8. Here bicarb is 7. 1.5 into 7, 10.5 plus 8, 18.5. So according to Winter's formula, we expect around 18 PCO2 if there is full compensation. If there is full compensation for metabolic acidosis, we expect 18.5. But here PCO2 is 23. Here CO2 is more than expected. We expect 18.5, but here CO2 is 23. It is more than expected. Means there is additional respiratory acidosis process. There is additional process causing accumulation of CO2. Means there is additional respiratory acidosis. So it is a case of metabolic acidosis with respiratory acidosis. So step 1 is whether acidosis or alkalosis is present or not. Step 2 is metabolic or respiratory. Step 3 is compensation, look for compensation. Step 4 is if there is metabolic acidosis, look for anion gap. Normal anion gap is 10. Here anion gap is, what is the anion gap here? 30. Anion gap, here it is 30, 30.7, around 30. Normal anion gap is 10. Here anion gap is high, very high. So 30 anion gap. Means metabolic acidosis can be either with high anion gap or normal anion gap. High anion gap metabolic acidosis is called HAGMA, H-A-G-M-A. Normal anion gap metabolic acidosis is called NAGMA. Here it is high anion gap metabolic acidosis. Once you identify high anion gap metabolic acidosis, then next step is look for delta anion gap. There is a gap ratio. What is the formula for delta gap? Change in anion gap by change in bicarb. Here measured anion gap minus normal anion gap. Measured anion gap is 30. Normal anion gap is 10. 30 minus 10, 20. Divided by normal bicarb minus measured bicarb. Normal bicarb is 24. Here measured bicarb is 7. So 24 minus 7, 17. The formula is for delta anion gap, measured anion gap minus normal anion gap divided by normal bicarb minus measured bicarb. Here it is 30 measured anion gap minus normal anion gap 10 divided by normal bicarb 24 minus measured bicarb 7 means 20 by 17. Here the ratio is more than 1. So what is the importance of the delta gap? The idea is the increase in anion gap should match with decrease in bicarb. If there is anion gap increase of 20, we expect bicarb to be 24 minus 20. In diabetic ketoacidosis, that ratio should be 1. So increase in anion gap should match with a deficit in bicarb, then the ratio will be 1. If the ratio is 1, it means it is a straightforward pure case of high anion gap metabolic acidosis. If the ratio is more than 1, what does it indicate? So we expect here bicarb to be 4. Here the difference in anion gap is 20. So here in the bicarb we expect 4 bicarb for the ratio to be normal. For here bicarb is 7. It means there is additional metabolic alkalosis process. If ratio is more than 1, that indicates that there is additional metabolic alkalosis process. There is accumulation of bicarb, more than expected bicarb is there. So this is a case of high anion gap metabolic acidosis, respiratory acidosis and metabolic alkalosis. So case of triple acid based disturbance. So what is the importance of identifying each process? What is the practical, what is the clinical importance? If you don't know how to interpret ABC, directly if we look into ABC, we assume that so pH is 7.0, acidosis, bicarb is low, 7, metabolic acidosis, CO2 is low, respiratory alkalosis. We assume that it is a case of metabolic acidosis with respiratory alkalosis. How do you manage respiratory alkalosis? One option is how to increase CO2. With a closed mask, we can rebreathe paper bag and we will inhale the same gas. If we repeat it for 7 or 10 times, then CO2 will increase. If we assume that if it is a case of respiratory alkalosis, if you do that maneuver, there will be CO2 increase. There will be further increase in respiratory acidosis. Here there is already respiratory acidosis. That is one point, that is one practical point. Second is, if there is full compensation, in a case of metabolic acidosis, if compensation is near normal, here we expected CO2 of 18. Here if CO2 is 18, it means full compensation. Then we won't expect any abnormality in the chest X-ray. It's a case of pure metabolic acidosis, we won't expect any abnormality in the chest X-ray, we won't expect any lung abnormality. But here, if you identify an additional process of respiratory acidosis, we expect lung abnormality. Then we will carefully look into chest X-ray. If it's not found in chest X-ray, we can do CT chest. We will carefully look into lung parenchymal causes. So for that, we should know all the causes of respiratory acidosis. First, we should know all the causes of respiratory acidosis. Then we will identify what could be the cause for respiratory acidosis in this case. So all the causes of respiratory acidosis are from brain. If you take central hypoventilation. Hypoventilation means maybe due to sedation, hypnotics, drugs, or vascular causes, infective causes. Then neuromuscular causes, poliomyelitis, kyphoscoliosis, myasthenia, muscular dystrophy, or central airways causes, airway obstruction. Then parenchymal causes. Parenchymal causes again pneumonia, ARDS, emphysema, pneumoconiasis, secondary to barotrauma, all are parenchymal causes. Other causes are obesity, hypoventilation, or permissive hypercapnia in ventilator patients. So these are all the causes of respiratory acidosis. So central hypoventilation, we should look for neuromuscular causes. Even simple electrolyte abnormality can cause neuromuscular weakness. The patient has severe hypokalemia or hypomagnesemia or hypocalcemia. Those abnormalities can cause respiratory muscle weakness. So we should look for those causes, central causes, neuromuscular causes, and major airway obstruction causes, bronchoasthma, COPD, or some obstruction, and then parenchymal causes. Then other causes for high CO2. So here, chest X-ray, we found a significant pulmonary edema, diffuse alveolar pulmonary edema. So that is the cause for respiratory acidosis. And what is the cause for metabolic acidosis in this case? High anion gap metabolic acidosis. There are 4 important causes for high anion gap metabolic acidosis. Easy mnemonic is CULT. Remember KULT. K for ketoacidosis. Ketoacidosis again, diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis. U for uremia. L for lactic acidosis. T for toxins. So ketoacidosis, uremia, lactic acidosis, and toxins. In this case, there is diabetic ketoacidosis. Urine showed ketones. So what are the criteria for diabetic ketoacidosis? There are 4 important criteria. So blood sugar should be more than 250. pH should be less than 7.3. If it is in between 7.3 and 7.25, say mild DKA. In between 7 to 7.25, moderate DKA, less than 7, severe DKA. So pH should be low. Then bicarb should be less than 18. So in between 15 to 18 we say mild DKA, 10 to 15 moderate, less than 10 severe. Here bicarb is 7. It's a case of triple acid based disturbance. High anion gap metabolic acidosis, respiratory acidosis, and with delta ratio we found that there is additional metabolic alkalosis process. Okay. So here the cause for respiratory acidosis is parenchymal cause. There is significant pulmonary edema, alveolar pulmonary edema, that is a cause for respiratory acidosis. These are the two important points. If you identify additional process of respiratory acidosis, we will carefully look into chest X-ray. There can be radiological lag. So second or third day also we will carefully look into chest X-ray. Sometimes X-ray may not show any abnormality. In that case, if there are symptoms, we should look for CT chest. We should rule out all the causes of respiratory acidosis. Lung is completely normal. Chest X-ray, CT are normal. If there are no symptoms, then we should look for electrolyte abnormalities. All causes for respiratory muscle weakness. Even hypophosphatemia can cause respiratory muscle weakness. If we give glucose infusion, that can cause hypophosphatemia. There will be more phosphate entry into cells. So that can cause respiratory muscle weakness. So we should carefully look for all causes of respiratory acidosis. In this there is straightforward cause, lung parenchymal disease, alveolar edema. So third acid base abnormality is metabolic alkalosis. How did you find metabolic alkalosis in this case? Delta ratio is more than 1. So what could be the cause for metabolic alkalosis in this case? For that we will discuss. First I will enumerate all the causes of metabolic alkalosis. So metabolic alkalosis can be due to exogenous alkali administration. If you give IV bicarb, exogenous acute alkali administration, or milk alkali syndrome. There are exogenous alkali administration causes. Then most important causes are, we should differentiate into 3 categories. In the approach of metabolic alkalosis, we should differentiate into 3 categories. First category is extracellular fluid volume contraction, normal or low BP, hypokalemia, increased hyperrenemic aldosteronism, hyperaldosteronism. This is the first category. So here patient presented with hypotension, and that hypotension causes secondary hyperaldosteronism. Secondary hyperaldosteronism can cause metabolic alkalosis. So here the causes for ECF contraction means hypovolemia, hypokalemia, and secondary hyperaldosteronism. Okay. There are gastrointestinal causes and renal causes. The gastrointestinal causes: vomiting, nasogastric drainage, congenital chloriduria, or gastrocystoplasty, villus adenoma, hypertrophic pyloric stenosis. So all causes of vomitings and nasal drainage and chloride loss. Basically chloride loss from the gastrointestinal tract. So chloride loss will be compensated by bicarb accumulation. That causes metabolic alkalosis. These are gastrointestinal causes. Then look for renal causes. Most important cause of metabolic alkalosis in the ICU setting is diuretics. This patient is not on diuretics, but most important cause of metabolic alkalosis is diuretic usage. Okay. Renal causes in this category are diuretics, post hypercapnic state. Hypercapnia means high CO2. Post hypercapnic state there can be metabolic alkalosis. Hypercalcemia, hypoparathyroidism, recovery from lactic acidosis, ketoacidosis, or usage of non-reabsorbable anions, penicillins, carbonicillins, magnesium deficiency, potassium deficiency, Bartter syndrome, Gitelman syndrome. These are the gastrointestinal causes in this category. Okay, we will discuss mechanisms. So, what is the mechanism in the diuretics? Diuretic, especially loop diuretics and thiazide diuretics. Loop diuretics acts on thick ascending limb of loop of Fennel. Okay. Here it is lumen cell. So loop diuretic action it inhibits sodium potassium 2 chloride channel. The loop of phenyl, the main channel is sodium potassium 2 chloride channel. This channel causes absorption of sodium, potassium and 2 chloride. So loop diuretic acts on this channel, inhibits this channel in the thick ascending limb of loop of phenyl. So if there is inhibition of this channel, what happens? There will be increased sodium entry into distal tubule. Increased sodium entry into distal tubule. In the distal tubular epithelial cell, there will be increased aldosterone action. If there is increased sodium entry into distal tubule, there will be increased aldosterone action. Aldosterone causes sodium entry and potassium hydrogen secretion. Aldosterone causes sodium entry into the cell and potassium hydrogen secretion. So hydrogen secretion causes alkalosis. Potassium secretion causes hypokalemia. Okay, there will be inhibition of sodium potassium 2 chloride channel by the loop diuretics. So that causes increased sodium entry into distal tubule. Here there will be aldosterone action that stimulates potassium and hydrogen secretion. Okay. So because of loop diuretic action, there will be hypovolemia, normal or low BP, and hypokalemia and increased aldosterone activity. So what is the action of thiazide diuretic? Thiazide diuretic action is on distal tubule in the sodium chloride channel. The distal tubule sodium chloride channel. It inhibits sodium chloride channel. Again there will be more sodium entry into distal epithelial cells. So aldosterone activity will be increased if there is more solute entry into the distal tubular epithelial cells. Whenever there is more sodium entry into the distal tubular epithelial cells, there will be increased aldosterone activity. Sodium will be absorbed, potassium hydrogen are secreted. So that is in diuretics. What is the mechanism in post-hypercapnic state for metabolic alkalosis? Hypercapnia, increased CO2, respiratory stenosis will be compensated by metabolic alkalosis. After that hypercapnia phase, there will be a phase of metabolic alkalosis. That is post-hypercapnic metabolic alkalosis. Then hypercalcemia. In hypercalcemia, the mechanism is high calcium inhibits this channel, NK2CC channel in the thick ascending limb of loop of phenyl. Hypercalcemia, the high calcium inhibits this channel. That is the mechanism. Same mechanism as loop diuretic. Recovery from lactic acidosis. During the recovery phase, lactate will be converted into bicarbonate. There will be bicarb accumulation. And if you give bicarb during lactic acidosis phase, severe acidosis, that bicarb will be accumulated. After recovery from lactic acidosis, there will be a metabolic alkalosis phase because lactate will be converted to bicarb. That is one mechanism. And high non-reabsorbable anions means penicillin, carbopenicillin group. High non-reabsorbable anions means again there will be more solute entry into distal tubule. More solute entry into distal tubule. That causes hydrogen and potassium secretion. That hydrogen secretion causes metabolic alkalosis. Then magnesium deficiency. Magnesium action is here in the thick ascending limb of loop of phenyl. Apart from sodium potassium 2CC channels, there are two other channels. One is ROMK channel for potassium secretion and BK channel. These two are for potassium secretion. Magnesium inhibits this channel, ROMK channel. Magnesium inhibits this channel, ROMK channel. ROMK is renal outer medullary potassium channel. BK is big potassium channels. So magnesium inhibits this ROMK channel. So if there is magnesium deficiency, there will be increased activation of ROMK and potassium secretion. That causes hypokalemia. Hypokalemia causes alkalosis. There is hypokalemia, the hydrogen potassium exchange mechanism. There is hypokalemia. In the hypokalemia case, hydrogen potassium exchange mechanism, there will be more entry of potassium into the cells and hydrogen will be secreted. So magnesium deficiency, potassium deficiency. And Bartter syndrome and Gittelsman syndrome. Bartter syndrome, there will be inhibition of genetic inhibition of sodium potassium chloride channel. Gittelsman syndrome, there will be genetic inhibition of sodium chloride channel. Okay. Bartter syndrome, it behaves like loop diuretic action. Gitelman syndrome, it behaves like thiazide diuretic action. In those two syndromes, again there will be more sodium entry into the distal tubule. That causes aldosterone stimulation and hydrogen potassium secretion. So, first category is extracellular fluid volume contraction, normal BP, hypokalemia, increased hyperenemic hyperaldosteronism, high renin and aldosterone action. Coming to the second category, increased extracellular fluid volume, extracellular fluid expansion, hypokalemia, so high BP, hypertension and mineralocorticoid excess. In this category, we should look for renin levels. There is high renin levels or low renin levels. Okay. If renin levels are high, in the renin angiotensin aldosterone axis, if renin levels are high, aldosterone levels will be high. But aldosterone causes potassium hydrogen secretion, that causes metabolic alkalosis. If there is more sodium retention, it causes ECF expansion, extracellular fluid expansion. Okay. There is more sodium retention by aldosterone, there will be ECF expansion. BP will be high. Because of aldosterone action, there will be hypokalemia. So, ECF expansion, hypokalemia, high BP, mineralocorticoid excess. If renin is high, the important causes are renin secreting tumors, accelerated hypertension, renal artery stenosis and estrogen. We should look for all the causes of high renin. Okay. In the low renin causes, it means there is primary aldosterone stimulation. Okay. There are primary causes in the adrenal gland hyperplasia, carcinoma. So, we should look for the adrenal gland causes, adrenal tumor, hyperplasia and carcinoma. There can be enzyme deficiency, 11 beta hydroxylase deficiency or 17 alpha hydroxylase deficiency. The enzymes, they convert cortisol to cortisone. 11 beta hydroxylase converts cortisol to cortisone. If there is deficiency, if there is genetic inhibition, there will be cortisol accumulation that has mineralocorticoid activity. Okay. Or apart from genetic inhibition, even licorice, carbenoxolone and chewing tobacco, there are some food additives, they can inhibit 11 beta hydroxylase. And in Cushing syndrome, it has mineralocorticoid activity. So, the main mechanism is mineralocorticoid excess. That will cause sodium retention, high BP and increased extracellular fluid and hypokalemia. Okay. Then third category, increased extracellular fluid, hypokalemia, high BP and hyporenemic hypoaldosteronism. So, aldosterone action is sodium retention. That sodium retention occurs through ENaC channels, epithelial sodium channels, ENaC channels. So, in this category, there will be excess ENaC channel activation. There will be stimulation of ENaC channel activation. That is called Liddle syndrome. So, if there is increased ENaC channel activation, that is Liddle syndrome, again there will be sodium retention, hypokalemia and ECF volume excess. Here the mechanism is ENaC cell activation. So, there is high BP. If there is high BP, high in extracellular fluid volume, what happens to renin and aldosterone levels? They will be inhibited. Here the mechanism at cellular level, at the receptor level. So, ENaC cell activation causes decreased renin and aldosterone levels. So, that is hyperenemic hypoaldosteronism. These are the three important categories for metabolic alkalosis. So, in this case, among those causes, what causes we should look for? So, there is no alkali administration, no history of taking soda bicarb. Then gastrointestinal, it has given history of vomitings. During feeding, she has complained of vomiting. Probably one cause, vomiting, the gastrointestinal causes. The renal causes, she didn't use diuretics. Acidosis, metabolic acidosis. The lactate is 12. The lactic acidosis, diabetic ketoacidosis. So during recovery from lactic acidosis and diabetic acidosis, there can be metabolic alkalosis. We didn't check magnesium. There is magnesium deficiency that can cause metabolic alkalosis. So routinely in the emergency department for critical cases, we should check magnesium also. Apart with sodium, potassium, we should look for calcium, magnesium, phosphate also. So even simple hypomagnesemia can cause metabolic alkalosis and hypokalemia. So in this case, potassium is normal. So probably these causes, one is vomiting, two recovery from lactic acidosis and diabetic ketoacidosis. Okay. So the case of triple acid base disturbance, high anion gap metabolic acidosis, respiratory acidosis and metabolic alkalosis. Okay.